everybody to this, the fifth in 2015's QI Connect WebEx sessions. Now already the regular QI connectors of you will be sat there thinking, my goodness, Brian doesn't sound like himself today. Let me explain that one straight away. Brian Robson, who is our regular chair for these sessions, can't be here today, so I'm stepping in on his behalf. Angelina Foster, it's my great privilege to be the Chief Executive of Healthcare Improvement Scotland, and my real pleasure today to be your chair. Firstly, quick bit of background. This series came from a request from our national clinical leads here in Healthcare Improvement Scotland, and they did it to connect frontline clinicians interested in quality improvement with international leaders in the field of QI. They asked particularly that we make these sessions short, accessible and recorded to allow access at a time that suited them. And of course, all those requirements apply wholly for all our non-clinical colleagues as well. So before we get going with the main content of our session today, let's just go through a few housekeeping items, and for that I'm going to hand over to my colleague, Jennifer Graham.
Thank you, Angelina. Welcome everyone to the session. So I'm just going to take you through a couple of housekeeping slides and to give you background just to the technical side of WebEx. If you could please just use the chat function on the right-hand side of your screen. We're really keen that this is a really fun, interactive session, so we'd encourage you to add comments and questions throughout Mary's talk, and we've got time at the end for Q&A, so we'll be putting those to Mary at the end. Any technical difficulties you have in the session, if you could just message the BT call manager through the WebEx chat function, or press *0 on your telephone. So we're just trying to encourage everyone to use the chat function on the right-hand side. So if you wish to make a comment or ask a question, if you can just type that into the white box at the bottom right-hand side of your screen and then to all participants. And we'll just try and keep that really interactive throughout the session. So let's now go on to the fun interactive part where we ask you start clicking on your computer, so we just want to find out where you're actually joining us from. So if you just click on the blue arrow to the top left-hand side of your screen, it's just circled there, and then just click on the map to show where you're actually joining us from. The mark for America. The technical difficulties there, I think we'll just move on. Yeah. So just to give you a bit of background on the QI Connect series, recently we now actually have 263 organisations linking into the series, and it's just grown so quickly. We have 43 countries linking in, which is amazing. I think the latest one was Togo in Africa. I started off the series and we had one slide with the logos of the organisations linking in. We now amazingly have 6 slides, so 1, 2, 3, 4, 5, 6 slides of logos of organisations linking into the series, which has been fantastic. I'm just going to just give you just a special mention to a few new organisations joining us. So we have 23 universities who link into the series, bringing students together to listen, learn and share in classrooms around the world. The 2 latest universities we have is University in Milan and also Swansea University as well. To some of the other organisations joining us today, I'm delighted as always to have colleagues join us from Singapore. We have Singapore Health Services, we have National University Hospital in Singapore, and we have Shanghai General Hospital in Singapore. We also have Strathcarron Hospice, Sam H in Scotland, Behold Hospital in Norway, Danish Institute for Quality European accreditation in healthcare from Denmark, and colleagues in Kaiser Permanente. So listen to the session today, and I hope you enjoy your first QI Connect. So the global reach of 43 countries have some challenges for us in terms of time zones. So we actually record each of our QI Connect sessions, and we make these available on our website so that clinicians can actually link in and watch the session at a time that suits them. Particularly, we actually had our friends in Coabatea in New Zealand bring staff together for lunchtime sessions to watch the recording and just listen, learn and share, which is great. We're going to also say that QI Connect is included as an approved resource within ISPA's fellowship programme. Just to let you see our wee team in Healthcare Improvement Scotland who support our QI Connect series. So to Brian Watson, who's our Executive Clinical Director and Series Chair, and wasn't able to make it today, but Brian's really been the innovation and energy behind QI Connect. We have Carmen Forrest, who is the Certification and Administration Officer, Ross Stewart, who can't with us today, is our Data Analyst and Project Officer. We're delighted to have Angelina Foster as today's session chair, and Angelina is the Chief Executive of Healthcare Improvement Scotland, and we also have Michelle Fleetchie, who is our registration lead for the series. We're delighted to say that for each of the sessions we identify a colleague who will ask the question on the session, and the question is going to be asked by David Maxwell at the end, and David's our improvement advisor focusing on medicines within the Scottish Patient Safety Programme. Always really keen to ensure that we have a strong social media presence throughout the QI Connect session. So if we could just encourage you to tweet as you learn, and just include our hashtag there, so it's hashtag HISQIConnect, and you can follow us at HISQIConnect on Twitter. So I'm now going to just hand you back to Angelina, who's going to introduce our amazing speaker for today.
Thank you, Jennifer. And as you know, everyone, our amazing speaker for today is Professor Mary Dixon-Woods. Mary is Professor of Medical Sociology and Director of the Sapphire Group, Department of Health Sciences at the University of Leicester, UK. She's also Deputy Editor-in-Chief of the BMJ Quality and Safety. In truth, she also holds a string of other positions, far too many for me to squeeze into our limited time today. Suffice to say, she is an absolutely terrific player, and we're hugely grateful to have her here. I also need to tell you that she's joining us today from New Hampshire, despite the considerable challenges of very dramatic, nasty-sounding weather conditions. So, Mary, we are doubly grateful to you for joining us today. Can I hand over to you?
Thank you very much. It's a really great pleasure to join you all, and thanks very much to the team for inviting me and for their great support in getting this session set up. I'm going to talk about what's so tough about patient safety today, and I'm going to identify 6 stages really. I'm going to start by talking about the problems of figuring out whether care is safe. I'm going to identify challenges related to fugitive knowledge and structural secrecy. I'll then move on to talking about the ironies of measurement, the problem of magical thinking in safety improvement, the challenge associated with getting both the technical stuff and the implementation right, and I'll end by talking about the problem of many hands. So let's start by discussing why it's so hard to know whether care is safe. Well, as Charles Vincent and colleagues have pointed out in their recent report for the Health Foundation, there is no single measure that will tell you whether the care you provide in your organisation is safe. But we have unfortunately become somewhat fixated on the idea that somehow something like standardised mortality rates or some other measure will tell us whether we are safe. And the truth is that there is no measure. In states, there are various attempts to rank hospitals in terms of rankings. And these are publicly available on websites and so on, and a recent analysis has shown that in fact those hospital rating systems share very few common scores, and that organisations that score well on one of these schemes often does poorly on another. So the authors of this report concluded that those ranking systems actually generate confusion rather than clarity, and that's because of the problems associated with getting measures. A second problem linked to knowing whether your care is safe is that it's actually very difficult to measure rates of harm. It's very easy to underestimate the technical difficulties associated with measurement, and a lot of the instrumentation we have available for very common problems is actually quite poor and difficult to use. So anyone, for example, who set out to measure medication errors will tell you that that's extraordinarily difficult to measure and measure reliably. We have tried to look at how the sausage gets made in terms of producing data on harm. We find that there are many, many complexities which are often go unreported. So, for example, when we studied how intensive care units were collecting and reporting data on central venous catheter bloodstream infections, we found that setting up the data collection systems was very challenging, but also many, many difficulties in interpreting the data and producing data that could be reliable and comparable across different settings. So we concluded from that study that setting up data collection systems is often very, very difficult for clinical teams, and that we still have not got a very good fix on issues of comparability. So measuring harm is pretty tough, but even when we can measure it, past harm is just one guide to whether your systems are currently safe, and it's actually a pretty imperfect guide. So we know from everyday life that you can't rely simply on incidents that have happened in the past to know whether a situation now is safe or dangerous. So, for example, it was no good to the owners of the Titanic that it had never sunk before. It hadn't had an opportunity to sink, but an assessment could have shown you that there were many vulnerabilities in the system. What we know from research in other industries, and particularly studies that have looked at situations where catastrophes have occurred, is that very often there's an incubation period that is evident leading up to an incident. And during that incubation period, latent errors, in other words, the kinds of errors that predispose towards a catastrophe occurring, and various events tend to accumulate. These studies also show there are often failures of intelligence, and there may be drifts in what's considered to be unacceptable or acceptable practice. Time, for example, things begin to appear normal, or as the way things are done around here, when in fact they are producing this predisposition towards an event occurring. What also happens is that you get the discounting of warning signs, so people tending to write off smaller incidents as occur as being evidence that maybe there isn't that much wrong at all. So William Hetty, who is a 17th century researcher, one of the earliest epidemiologists, argued that if you want to know what's really going on in a hospital or in a healthcare setting, then you're much better off going there and looking than you are simply inspecting by looking at the data. So he said, one learn to know and distinguish a face better by 1 minute's inspection than by reading 10 sheets of paper. So he's basically arguing that you need to have multiple sources of data and intelligence if you want to draw conclusions about whether your care is safe. And I think that's just as true today as it was 300 years ago. And this, again, we know from everyday life. We don't need to have a report on incidents to know whether this structure is a good place to pitch your picnic. We can tell pretty much by looking at it that that many dangers abound in this particular setting. But we're not so good at looking at something like a pharmacy and doing the same kinds of assessment. We're still inclined to look much more at incidents, rates of harm, errors, and so on, in order to make an assessment of, say, whether the entire medication delivery system is safe. So one of the things that the Health Foundation has done recently has been to commission work looking at whether tools and techniques used in other high-risk industries that are oriented towards proactive detection of risk that can be complemented by measures of harm, but that actively go out and make assessments of where the vulnerabilities and fallibilities in systems might lie, so that you can proactively detect those and repair them. And that work was very successful in demonstrating that clinical teams can actually identify those risks and hazards in their systems. And it was published just a few months ago in a report that's available for free from the Health Foundation website. What that work showed is that when you ask clinical teams to map their clinical systems, you often find that these systems have never been purposefully designed, and that when you peel them back, you often find that people don't even agree on the same idea of what the clinical pathway is. They don't have clarity about role expectations. They don't have clarity about systems, about procedures and processes within those clinical pathways. Basically, what happens then is that these clinical pathways, or microsystems, as various words used to describe them, are fraught with the potential for error. They're often extremely frustrating for staff to use, and staff can spend a huge amount of time accomplishing basic tasks because there isn't reliability or clarity of those systems. So what we found when we did the evaluation of this program, which was called Safer Clinical Systems, is many clinical microsystems are basically piecemeal in nature. Nobody ever sat down and designed them. How they function in practice is often very poorly understood. And they basically work because the staff make them work. The staff go to enormous lengths to rescue situations that go wrong. They put huge effort into getting things right for patients. And as they do that, they make ad hoc improvisations and adaptations. And that can be very good in getting the system to work today for this patient. But it can also frustrate achieving peak performance, because in a way that work by the staff obscures these defects. And there's often very limited understanding of what it takes to get to really peak performance because of this. What we've also found is that when we talk to the blunt end of systems, in other words, the sort of very senior executive end, there can be very poor grasp of the operational detail at the sharp end, that there just isn't that connection between blunt end and sharp end in terms of what needs to be done in order to get these systems to work, and the amount of effort that's required to get the systems to work. This is very bad in all kinds of ways, but one of them is that if you are working in systems that have many cues of disorder, that has an impact on performance. There's a fascinating series of studies from the Netherlands where they basically altered the environment and looked at what it did to people's behaviour. And this is one based in a car park where, in the control condition, the trolleys are all neatly put away. And when people come back to their cars in the control condition and they find one of those annoying flyers for pizzas on the windscreen, they will litter it about 30% of the time. But you leave the trolleys out all over the place, so you're providing a cue of disorder. People litter about 60% of the time. That kind of environmental cue about what is valued around here is really quite important, and I think we have sometimes underestimated the impact of that on people's practices and behaviours. So I'm going to turn to the problem of fugitive knowledge and structural secrecy now, and this is linked to the kinds of problems related to intelligence I've just been talking about. But fugitive knowledge is the kind of knowledge that's often the most valuable in terms of knowing whether care is safe in organisations, but also the kind that most evades capture. Sometimes it evades capture because it's very difficult to find. It may be in the form of rumours and gossip. It may have what we call a forbidden character, so even knowing this information is dangerous for the person who knows it, and it could be dangerous to express it. sometimes the knowledge that you most want has a kind of uncertain evidentiary quality, so it's difficult to demonstrate it. It may be an intuition, it may be a sense that something is wrong, but it's difficult to actually prove that your intuition is correct. Diane Vaughan's brilliant analysis of the NASA Challenger disaster talks about this problem of silencing and secrecy in a very interesting way. So she talks about a problem called structural secrecy, and basically this is not necessarily a conspiracy, and it's not necessarily anything that anyone intends, but the result is that the way that patterns of information, organizational structure, processes and transactions, and the structure of regulatory relations systematically undermines the attempt to know. So she's saying that it is very, very difficult to actually know what's going on because of the way systems are set up in organizations. Diane Vaughan also identified, and which is very relevant to a lot of patient safety problems, is a term that's a little off-putting, but she basically calls it the normalization of deviance. And what she means by that is that you get very used to poor quality systems. Because the systems don't function properly, people start to use workarounds and shortcuts. And when you get to no harm, no foul, in other words, you're kind of using these shortcuts all the time and nothing goes wrong, then it makes it very hard to challenge. So basically, over time, something that's actually a poor practice or a poor system comes to be tolerated, it comes to be seen as normal. And that then frustrates attempts to repair those systems. When we a huge study of culture and behaviour in the English National Health Service led by Michael West and using multiple methods, we found that there was another problem that got in the way of knowing whether care was safe. And this is that when you look at the senior level of organizations, they tend to display behaviors that range from what we call problem-sensing behaviors. So this means that you're actively out looking for where the problems lie in your systems, actually actively seeking out harm, actively trying to figure out what could go wrong around here, through to what we called comfort-seeking behaviors. And this is a behavior that's linked to looking at data or looking at evidence and finding a way to explain it away as being normal or as acceptable when perhaps really it isn't. And, you can identify these behaviors. It's not an English thing. It's something you can find in organizations around the world. But one of the things that can happen is when you have a comfort-seeking behavior is that people who've got comfortable messages to convey can get can be given not such a great welcome. And again, this is something that goes back through history. Since I'm talking to the Scots today, I thought I would start back in 1795 in Aberdeen, when the Dr. Alexander Gordon made the discovery that there was a link between doctors' hygiene practices and puerperal fever. But when he tried to raise this as an issue with his colleagues in Aberdeen, he was not treated well and ended up having to leave town without having solved the problem. 1843 in Boston, Oliver Wendell Holmes made pretty much the same discovery, but again was not welcomed by his colleagues, one of whom went so far as to say doctors are gentlemen and a gentleman's hands are clean. So end of story. When Ignaz Semmelweis in Vienna made pretty much the same discovery again, he was also shunned by his colleagues and ended up, by some accounts, ending his life in kicked to death by guards in an asylum. So a long history of really not wanting to hear bad news. And that's linked to problems of whether people in organizations feel entitled to speak when they have concerns. Some of the work we're doing on this at the moment suggests that it's linked to people's job status or experience, the extent to which they feel they do have evidentiary support when they raise an issue, their ability to use their personal social capital and tolerate threats to it, in other words, the extent to which they're prepared to put themselves at risk. These are all issues that those leading organizations need to be aware of. But also true that not all of this is necessarily to do with the way organizations are run. It's a kind of basic human instinct that in interpersonal relations, people are often keen to avoid conflict. And that may be conflict with your immediate peers that people are particularly motivated to avoid. We also have found that listening is not a simple function of hearing, that it's not actually always straightforward for leaders in organizations to hear the bad news or to figure out what's important about all of the bad news that they may be hearing. So leaders in organizations are often confronted with the problem we call the problem of many voices. And this may be that there can be very loud buzz in organizations, a lot of people speaking, a lot of concerns being raised, and it can be very difficult to figure out what is the kind of information that you should value, who do I listen to, given that there's only ever going to be a limited amount of managerial attention. But let me tell you what can go wrong when you don't listen to those voices and when you discount information that may be discomforting. So let me take you to Texas, January 2005, and a survey at the Texas City oil refinery plant, which was conducted in January 2005, found that the workers at this plant were reporting an exceptional degree of fear of catastrophic incidents, felt that they were blamed when they got hurt. They reported that there were massive production pressures that were taking precedence over other priorities, and they felt that managers were forced to make compromises. So it's available that of concern about safety at this plant. 2 months later, there was a massive hydrocarbon vapor cloud explosion. It killed 15 of those workers and injured 170 more. It was a massive disaster. But just 5 years later, same company, we moved to the Gulf of Mexico, and now it is clear that the measure related to workers feeling safe is an important one, and senior officials visit a rig to celebrate 0 personal injuries for 7 years. Late that day, the rig caught fire. 2 days later, it sank, and that oil spill, which was Deepwater Horizon, was the worst environmental disaster in U.S. history. Again, what seemed to be going on there was that although there was a focus on a specific measure, the concerns that workers were raising, which were evident in a survey again conducted about a month before this disaster, had not been heard. And so a failure of intelligence that could have helped avert disaster. Let me get now to discussing some of the ironies of measurement. So what happens when we do try to collect data and figure out what to do in response? One problem that we have come across repeatedly, both in the US and the UK, is the crowding of the policy space. And this is a problem that occurs when there are multiple bodies in a policy space that have some kind of control function, some kind of say over what organizations are doing. And these can be of many different kinds, even when they're not explicitly defined as regulators. There may be all kinds of bodies who are allowed to demand data or exercise some kind of control over healthcare organizations. You get that kind of crowding going on. You can often get policy incentives that are too many. They can conflict, compete, or fail to cohere and result in unintended or unwanted consequences. And that can include interfering with the ability of organizations to develop a coherent mission and vision of their own. This is called the problem of many eyes, and basically it is a major problem for healthcare organizations because they end up having basically too many masters. In the US, studies have looked at how many measures organizations are now being asked to provide data on. In 2011, the number of National Quality Forum measures went to 700, having previously been 200. The U.S. Center for Medicaid and Medicare Services introduced 65 new measures in that year alone. And at Massachusetts General Hospital, measurement consumes 1% of net patient service revenue. Huge amount of effort going into the measurement task. But what it can result in is the problem we call priority thickets. And basically, when you've got too many externally imposed priorities, you can end up with distraction, frustration, loss of focus, and energy. So a real problem for organizations. And at the time as we are doing all of this measurement, there are other things that we don't measure at all or measure pretty badly. So this paper published in the New England Journal of Medicine about 18 months ago, I think, is a real game changer. And basically what this showed is that the outcomes of surgery can pretty much be predicted by surgeons looking at videos of the surgeon's skill. And what this study showed is that operator skill is highly predictive of surgical outcome, and matters probably more than many of the other things that we do measure. But at the moment, we don't do any measuring of skill issues. We also know from that study I mentioned earlier that things that are really important to patient safety include clarity of goals at every level, from the blunt end of organizations through to individual teams and individuals. Do people know what they're doing? Do they agree on those goals? We know that warm, supportive human resources management is absolutely critical, and we know that well-functioning teams are critical to delivering safe care. But again, these are things that we don't measure. We leave them unmeasured. And what we also know is that when attempts are made to go out and look for this fugitive data to try to gather information, it's often not done particularly well. The walk-rounds have been a very widely promoted intervention, but in this study that we published in the Journal on Quality the Joint Commission Journal on Quality and Patient Safety, we showed that sometimes they are used in ways that actually suppress information rather than encouraging it to come forward. So done badly can result in the illusion of control. People think they know what's going on, and the problem we call blind sight. So you're looking at your organization, you're looking at data, and you're actually forming an incorrect reading of what it's like in terms of safety. Measurement is often performative, and that's what I would just briefly discuss now. So measurement acts on what it measures. There's a famous book in sociology called An Engine, Not a Camera, by other of your Scottish compatriots, Donald Mackenzie at Edinburgh. And basically what that means is that it doesn't simply take photographs. Data is acting back on the systems that it describes. And so that there are two reactive effects that are particularly important in patient safety. One of them is gaming, and that's been widely discussed in the literature, but the second is effort substitution. The problem of gaming goes back really a very long time, back in fact to the plague, when they were trying to count plague deaths and people who had those infected with the plague in their houses, and the data was not always great. But it can occur particularly when people are held to account for targets that are very difficult to attain by other means. And Gwyn Bevan and Christopher Hood's paper on targets and terror, I think, has lasting relevance to understanding the pernicious effects of those kinds of targets, but also understanding that gaming is a really important problem. It then occurs in the US. Gaming seems to be a problem in other measures that have been imposed externally, including door-to balloon time for cardiac catheterization. But effort substitution, I think, is another problem, and it's a problem that everybody who works in healthcare will recognize. And this is the problem that what gets heard tends to be the thing that gets valued. And that can result in the eye being taken off other balls. So basically people start to divert their attention towards the thing that is being measured, and they may give less attention and less energy to equally important, possibly even more important things that aren't being measured. So we see this a lot with infections, for example. So the investigation into the outbreak of C. difficile at Stoke Mandeville concluded that basically other managerial imperatives were given greater priority than the control of infection, and there wasn't sufficient priority being given to the control of C. difficile in particular, because C. difficile at that point was not a target. Since been made a target, but now other things that are not being measured are becoming a real problem, so we still have effort substitution going on in terms of healthcare acquired infections. when we looked at what happened when a hospital tried to drive down its rate of missed doses, we found a similar effective effort substitution, that the nurses were so concerned about missed doses, which was being measured, that they diverted their attention from other things that might be very important to patient care. So this particular hospital was able to address that problem, but it's one that often goes unrecognised. The overall effect of this is that if you have poorly designed measurement systems, you can end up with bureaucratized defensive management that tends to be highly reactive, becomes very focused on what we call auditable moments and producing these visible traces of compliance, and a proliferation of forms, procedures and rules that can actually get in the way rather than helping patient safety. I'm now going to turn to talking about the problem of magical thinking in safety improvement, and this is something I get really quite preoccupied with. And I think what we have in patient safety is a tendency to engage in a conspiracy of enthusiasm, which was a problem identified by Donald Campbell going back to 1969. We have to be able to advocate without the excess of commitment that blinds us to reality testing. So too often when we're evaluating quality improvement programs or patient safety programs, there is a tendency to believe that whatever intervention has been selected is going to work, and that's not always the case. So what we also find when we look at policy directives is that there's often a tendency, there was a little rhyme my daughter used to love when she was about 4 that talked about the engines down at the station. Man at the engine pulls on the lever, puff, 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 and off we go. And it's rarely as simple as pulling on the lever. So we too often see policy prescriptions that don't understand the work that's in that engine that needs to be there for the train to leave the station. So we put a paper just a couple of months ago, which is free to download from BMJ Quality and Safety, on the practical role that theory can play in designing quality improvement and patient safety improvement efforts. What we're doing there is that everybody is using theory all the time, even if they don't realize it. And the job of improvers is to make the theories that they're using explicit and to discuss and agree them so that it's clear what they are trying to do. But too often, these slides haven't come out correctly. Too often what we see is that you get something like people say we're going to introduce an incident reporting system, and their assumption is that errors will go down, but it's not clear what is linking one to the other. So you need to have a clear theory that links why making that intervention would result in the outcome you want. Often we see policy interventions that don't understand this, that don't understand the need to engage in theory, and too often we see frontline teams do the same thing. So in the US, for example, there was a recent paper that showed that participating in a big quality improvement reporting program called NISQIP for surgical outcomes didn't improve outcomes. And part of the reason for that, in my view, is that the reporting system did not include feedback mechanisms that were designed on what we know about how to do feedback properly. So the feedback comes in and it doesn't identify goals, and it's inconsistent with good theory on feedback. It means that you basically end up with wasted effort. There is also the problem that many quality improvement interventions take the form of what I call babies, which means that their parents are very fond of them, but they are very hard to transport to other contexts, and parents of babies tend to resist the idea that perhaps their baby isn't the most beautiful in the world. So they're very hard to evaluate or hard to offer criticisms of, even when perhaps they're not the most effective solution. Another problem we know of with patient safety improvements is that there are often unintended consequences, and Doctor's book on the digital doctor, for example, identifies many of what he calls ironies of automation, that we've looked to electronic health records as a solution to safety problems, but in fact what they often do is simply introduce new risks. They may reduce some risks, but they introduce new ones as well. So in safety improvement work, we often have limited understanding of the mechanisms, what's making something work, We often have poor descriptions of intervention, implementation, and context. And my PhD student, Emma Jones, has been working on this problem of intervention description and shown that many quality improvement reports don't describe their interventions accurately, but also a discounting of the organizational, social, and emotional work needed to get improvement to work. Let me just give you one example of this, and the surgical safety checklist, which you will know is one of the most widely disseminated improvement interventions in the world, patient safety interventions, originally described in the New England Journal about 5 years ago. And if you look up the outcomes, so death and any complication with compliance, we see something very interesting. First, we see that the intervention, although it was implemented in 8 sites, was effective in only 3 of those. So the other 5 did not demonstrate a statistically significant difference before and after. If we look first of the 3 sites that does demonstrate a difference, there's certainly an improvement in outcomes, which is very welcome, but the compliance goes from 94 to 94. So hard to attribute the improvement to the checklist. If we look at the second one that seems to improve, that's number 5. Again, a welcome improvement in outcomes, but compliance goes from 0 to 0. And the last one, which is number 7, is the only one that goes in the correct direction, where we have an improvement in outcomes and in compliance. So here I'm struggling to match up what is linking the improvement to the outcomes, since it's hard. There's this chaotic pattern in terms of compliance. When a checklist was introduced in 2 hospitals in Liberia, exactly the same pattern emerged. In the first hospital, the checklist was associated with improved outcomes but not improved compliance, and the second one, improved compliance but not improved outcomes. When the checklist was introduced in Ontario in Canada, they were unable to find an effect associated with the introduction of the checklist, possibly because they were already doing pretty well, and it's hard to improve if you haven't got much headroom. And similarly, a recent paper by Justin Dimmick and colleagues found exactly the same effect. That it's hard to find any effect of the surgical checklist in Medicare patients in the US. When we looked qualitatively at what was going on when the checklist was introduced, we found that it did have some positive benefits, also some that weren't easily detectable without doing this qualitative work, particularly when we looked in low-income countries in Africa, in one low-income country in Africa. In fact, the checklist was increasing the hierarchies and was producing unwelcome effects like recording things as having happened to the patient when actually they had not. So to say there's anything wrong with the checklist, I have no doubt that the principles behind it are good ones, but as somebody who studies this kind of thing, I would like an account of the mechanisms through which it works, and I would also like it to be clear that it's not as simple as saying, here you go, come back when things are safer. It needs a lot more effort to make the checklist work. So coming to my talk now, I'm going to identify the challenges of getting both the technical stuff and the implementation right. Kind of simple but often neglected questions are: does the technical intervention work? Does the implementation strategy work? And were there features of context that intervened? And it's very helpful to divide up these questions this way. So many of you will recognize the bezoar stone here because it is mentioned in Harry Potter. And you may remember that Harry messed up one of his spells when he was occupied with asking Cho Chan to the Yule Ball. He forgot to include the bezoar stone, and therefore had a very poor outcome. The bezoar stone was widely used in medicine for many years and was believed to be an antidote to all toxins. It was, in fact, the gallstone of goats, and it was implicated in the death of Charles II. So Charles was ill one morning and was treated by his physicians. He had a bit of blood extracted from his right arm, a half pint from his left arm, an emetic, an enema comprising 15 substances. his head shaved and so on, and finally he was given the Bezoar stone, which seems to have finished him off. So he have perfect technical execution. The interventions were implemented correctly. It's just that the technical interventions were completely wrong. None of these things were going to help our patient. And we see this today. So sometimes we get good at giving patients things where technically the intervention is wrong. And this is a case, for example, for beta blockade. All surgical patients, which was being promoted for several years on the back of trials which subsequently turned out to be flawed. So in fact, the risk of death if you give beta blockade to everybody is increased. Sometimes the implementation wrong, so things that will work just don't consistently happen. And Jay Saint and others at Michigan have identified many of the reasons why this can happen in relation to infection control, and they have the lovely concept of active resistors, people who actively stop things from being implemented, but also organizational constipators, so people who do kind of passive-aggressive means prevent interventions from being consistently implemented. And we look at something like financial incentives for hospital-acquired conditions. We find that there often isn't full recognition that, in fact, technically we don't know how to solve some of the problems of patient safety. This is one of the reasons why this non-payment for hospital-acquired conditions has shown different effects for different kinds of patient safety problems. I'm concluding now by talking about the problem of many hands, and again, this is something that I'm very concerned about. Basically, quality improvement is an absolutely essential capacity for any healthcare organization. If you can't sort out the kind of basic, mundane problems that constantly frustrate staff and make for a poor experience and poor outcomes for patients, then it's very, very difficult to progress. So organizations, be they hospitals, be they care homes, any kind of team providing care to patients needs to know how to improve its systems, how to ensure that things happen reliably, how to smooth out clinical microsystems. That is absolutely essential. But I'm not sure it is fully the solution to patient safety, even though it is often promoted as the solution to patient safety. So I'm arguing here that it's a key component, but if we leave safety entirely up to local QI, I think we're missing an important part of the story. So all of the methods currently promoted in healthcare come from the work of Deming, who, as many people know, made a particular contribution towards improvement in industries like the automobile industry. What's less frequently described is that the auto industry made itself safe partly by agreeing on standards as an industry. So things like safety belts and so on, basic safety standards, are not left up to individual factories to do QI on. They are agreed as industry standards, and this is the way we're going to do things. The QI will be used to enhance the process, but not to agree on the safety standards. And I think we haven't always acknowledged this in healthcare. So on the Safer Clinical Systems Programme evaluation, this was one of our findings, that very often there's a problem with locating where it is that it is possible to coordinate action on a particular safety problem in order to solve it. And this is a problem Dennis Thompson, the political philosopher, calls the problem of many hands. And what he's saying is when you have many hands involved, the profusion of agents obscures location of agency. The many issues that underlie safety and quality are big and hairy. They can't be sorted out by small clinical teams because they're just too big. But we have continued to treat patient safety as an organizational problem, something that should be sorted out organization by organization, not as an institutional or global one. And this is when this has happened in other areas, you get known problems like structural amnesia. So I mentioned the Challenger disaster earlier, and as you all know, that occurred because of the failure of the O-rings, and which froze on a very cold morning. But exactly the same thing had happened happened in 1912, which is what defeated the polar expedition. The O-rings on their fuel cans froze, but that information didn't get passed from one setting to the next, and as a result, catastrophe eventuated. We have pretty much the same kinds of problems all the time in healthcare, recurring patterns of the same kinds of problems. The problems with dosing of methotrexate go back many, many, many years, but continue to recur today. When we leave the solution to these problems up to local QI teams, they can often come up with good solutions, but they may be different solutions for every setting. And then we get into the thousand flowers problem, that each of these solutions may be nice in its own way, but each needs to be looked after differently, learned each time. And they introduce new risks because we don't have standardized solutions across the industry, if you'd like to call it that. Example of this recently shared with me very kindly by the Southeastern Health and Social Care Trust in Northern Ireland in relation to ID wristbands, where they need a structural solution to a problem that can't be solved by local QI, even though the QI team did a great job of identifying the problem. The tragic case of Wayne illustrates what happens when you have local QI solutions to problems that actually should be agreed across the industry. Wayne died in part because the doctor who had moved to Nottingham was unaware of the system that was in place for was that the same system that had been in place in his previous job was also in place to prevent vincristine being available in the same bag as a drug for intrathecal administration. So, conclude. Would like to argue that patient safety is a social problem, that many bad outcomes are socially organized. In principle, they can be anticipated, prevented, or mitigated. I think we've often got organizational and institutional sclerosis that obscures danger and frustrates the kind of responses that we need, rapid or otherwise. I think we often have failures of intelligence, and I would say if you're not measuring, you're not managing. If you're rapidly, you're not managing, and if you're only measuring, you're not managing. I have lots of problems that are linked to coordinating action. Sometimes the elements of systems need close alignment and integration. Sometimes they need to operate largely independently, but I don't think we have sorted out what those elements are yet. We need better identification of points of authority and arrangements for coordination, but we also need agility. I think the sense of patient safety needs to mature more. We need better intelligence, we need better design of improvement efforts, we need better evaluation, and we need better understanding of the relationship between blunt end and sharp end of systems. And I'm now very happy to take questions.
So it's David here. Sorry, I just wasn't sure if you could hear me, and thank you very much. I have to say that there was so much in the presentation there that just resonates with some of the work that I think a lot of us are involved in. And I've been taking kind of plenty of notes around, the constant been challenges with agreeing some of the safety standards that, then as quality improvement teams would then work towards that, the testing and the small test of change, but to be all working towards the same thing. But I guess the things that you mentioned toward the end of your presentation was something that I'm quite interested in as well, as these recurring errors, the things that we've seen happen in the past and they're still happening now. And I'm wondering what you think about how we could become more proactive in detecting risk to try and overcome those recurrent things.
Okay, that's a question. I mean, there's probably two different things there, but one of them is that the problem of recurring harms is a really important one. And this is where I think we probably need more coordination rather than individual root cause analyses that then go back into the National Reporting and Learning System, and then a patient safety alert it comes out. Sometimes those alerts are very delayed and they're not always implemented very well. And I'd really love to hear ideas about how this kind of action could be coordinated better. It happens better in other industries. It doesn't happen perfectly, but I think we haven't quite got there yet. In terms of proactive detection, I think, again, that would be a great opportunity for people to work together across organizations and to use techniques that we've kind of underused in healthcare, like peer review and so on.
Thank you very much.
Okay, thank you both. Thanks also to all participants for your many messages of endorsement and resonance there. We've got a few questions. We won't have time for them all, but let's kick off with one from Liz Sutton. Liz is a research associate at the University of Leicester, and Liz is asking, from what you said to us today, what are the implications of this for the need to gather soft intelligence as distinct from the gathering of harder data?
Okay, we need both soft intelligence and hard intelligence. So I think some of the challenges I was talking about in terms of workers raising concerns and so on, a lot of the work for the future is going to be creating safe places for people to show those, also encouraging people to be very responsible about raising concerns. I mean that both in terms of voicing when they have them, but also not using patient safety as a kind of opportunity to raise all kinds of other issues, which I know can be a concern for senior people, that the category of what counts as a safety and concern can get too stretched. So I think there are lots of opportunities for improving our mastery of soft intelligence, and I'd really love to see more work on that.
Next one is from Fidelma Fitzpatrick. Fidelma is a microbiologist with the Bunt Hospital. Fidelma starts by saying how she finds your description of comfort-seeking very, very true, but then goes on to ask, does this differ perhaps, Mary, in countries with public reporting targets?
Public targets. So I think comfort-seeking can happen in all kinds of ways. I think sometimes public reporting can actually, on the one hand, encourage organisations to be more transparent, but on the other hand, it can sometimes conceal more than it reveals. And some of these target-driven interventions all around the world actually have been shown to have had both positive and negative effects. So I don't know if there's a very straightforward answer to the question, but I think there has to be more activity to the problem at policy level. I think there's been a tendency to reach for these kind of very punitive, coercive measures, and we do a lot better in terms of designing some of these policy interventions and understanding what really happens on the ground. So I think a great question, Fidelma.
Great. Next one from Tom Houston. Tom is a lead officer at NHS Forth Valley, and asks, do we know if most harm is caused by big events or by lots of little ones?
Interesting question. So that, in some ways, it's a very, very difficult question to answer. So basically, harm can occur without an error, and errors can occur without any harm. So occasionally errors happen every day, all the time, but rarely result in harm. When they do, they're often catastrophic, actually. Infections, similarly, they are not necessarily caused by contact with healthcare systems, but poorly run healthcare systems can increase risk. I would say that a lot of attention tends to go on big accidents, things that appear completely, have this kind of cinematic quality, appear very dramatic, things like wrong site surgery and so on, or errors that are fatal. But in fact, the work that Helen Hogan and other colleagues did, which was published in BMJ Quality and Safety just a couple of summers ago, on causes of death, showed that about 5% of deaths in hospital may have a preventable component, and most of those were related to quite mundane processes of care, things like fluid observations and so on. So quite to answer, is it big ones or little ones? I think we have a lot of little events that cause harm or discomfort or distress to patients, and that we could do better in addressing some of those.
This is going to be our final question for this afternoon, but any that we haven't been able to share with you, Mary, we will follow up separately. Next and final one is from Mags Watson. Mags is a Health Foundation Improvement Science Fellow at the University of Aberdeen. She's asking, where, in and of some of the concepts that you've shared with us today, do patients and the public fit? Just your sense of their role in this?
Terrific. So I think we are underusing patients and the public to report on incidents, and we're underusing them as a source of soft intelligence. I think we could also do better in terms of capturing some of those elements of avoidable harm when we're looking at other measures of care. The extent to which it's straightforward to involve patients and carers in redesigning systems is not clear yet. They will sometimes have an extremely valuable role, and sometimes it's less obvious that they can contribute in a meaningful way. And to my mind, it's not acceptable to bring patients in and use up their time if there's nothing they can contribute to. For example, a discussion of whether you should have a particular piece of equipment in the operating room, but it'd be absolutely invaluable in other areas. So what I'd like to see is more clarity about when patient and public involvement in systems redesign and patient safety implementation is a good thing, and when it's less useful, because then I think we can optimize that. But I think the kind of blanket approach that it's either all wonderful or it's all hopeless is not helping us at the moment.
Great. Huge thanks from all of us for a lecture there that was so rich in its content, but also delivered with such an eclectic range of ideas and illustrations. So thank you so much. Quick look from myself, just to trill for all of you. The next QI Connect lecture is from Dr. David Mates. The date, if it isn't already in your diaries, is 30th June, forget that, June, 30th June at 9 o'clock, so 9 o'clock to 10 o'clock UK time. As some of you may know, David Mates is Chief Executive of Canterbury and West Coast District Health Boards in New Zealand. David is passionate about health and what's possible when people just grasp the vision and work together for the greater good. The well-did achievements of the Canterbury health system are absolute testimony to his leadership. He has personally overseen the creation of what has been identified by the King's Fund as one of the most integrated health systems in the world. So that's your trailer for our next lecture. Finally, I'm going to hand you back to Jennifer just to draw this to a conclusion. Jennifer.
Thank you, Angelina. Just to alert everyone, so as Angelina mentioned, we have David Mates coming up in June, but we've got some fantastic speakers in our series for 2015, looking right across health and social care. So we have Maureen Bivignano lined up for July, Tracy Cooper, we have Jennifer Dixon and Paul Butalvin. So I would keep up to date just by following us on Twitter, as I mentioned before. Our handle is @HISQIConnect, and if you follow us there or just get in touch with the team at any time, we're happy to help. Thank you.